My name's Alex Schadenberg. I'm the Executive Director of the Euthanasia Prevention Coalition. I'm very pleased today to have with me, well, about 40 participants so far, but there's a lot more who've registered or still coming in. I've got Alexander Raikin. I also have with me now, Alexander did the research on this fabulous research document, and also Rebecca Vachon, who's the Health Program Director for Cardus, who will give us a bit of insight first into where the idea of the research came from, or the idea or the whole thing about Cardus having this research done, and then we're going to go straight to Alex Raikin, who's done a lot of work on this issue of the rise of euthanasia in Canada. So I'm just going to ask Rebecca to unmute herself and give an explanation of the whole work of Cardus in relation to doing research, etc., like this, and then we'll get straight to Alex or Alexander.
This is going to get confusing with Alex Schadenberg and Alexander Raikin. Thank you so much for welcoming us here today. Such an important topic, and we were so pleased to publish this report from Alexander. For those who aren't aware, Cardus is a nonpartisan think tank here in Canada. I direct the health program, and our program looks at a number of different issues, so not euthanasia exclusively, but also a lot of the other things in the ecosystem which are really important when you're thinking about the issue of euthanasia, like palliative care, medical conscience rights, social isolation. And so we take a real holistic approach in our research and policy recommendations in terms of how can we encourage the development of social systems that provide for the needs of Canadians in their living, and also as they approach the end of life and the decisions they're making there around. So this report came out of an interest in better understanding what is the state of euthanasia in Canada and how does that compare to other countries. It was great to have the opportunity to meet Alexander at another event a while back. And this actually, the genesis of this was that it's going to be part of a series of papers. So that's a teaser that there are 2 papers still to come. And this is just the start of that research process. And so I'm looking forward to hearing his presentation here today. There's been a lot of interest nationally and internationally in this research, a lot of headlines. And so looking forward to hearing more about that and also sharing in the discussion with all of you.
Alexander Raikin, tell us a little bit about yourself and start with telling us what your research has come up with.
Yeah, thank you for organizing this webinar. I'm a visiting fellow in Bioethics and American Democracy at the Ethics and Public Policy Center here in Washington, D.C. I couldn't figure out how to do the virtual background, so if I look like I'm in a hostage video, I assure you the demands were met, and EPPC is still happy to have me. I see some of my coworkers here. Yeah, this report is a series of reports that are looking into the data behind Canada's euthanasia program. I'll just share just a quick slide that I made. Okay. So part of this, the reason why I started looking into the data component about this was that it was a little bit difficult for me to understand why Canadian media as a whole wasn't really reporting accurately on the sheer incidence of MAID. Right, we know that MAID we've all seen the headlines about the growth of MAID, right? And every single year there's been something like a 30% growth, right? Well, if you have a 30% growth every single year since the program started, that's not just an incremental growth, right? So I wanted to look into this, and on top of this, we also knew that, I mean, just based off of the headlines, right? We knew that the Canadian Medical Association, when MAID, so I'll use the term MAID as well. MAID stands for Medical Assistance in Dying, which is effectively euthanasia. That's the colloquial term that Canada's Parliament just called it, and it stuck. So when MAID was first legalized, the Canadian Medical Association said that it was only appropriate in rare circumstances. The trial judge in Canada in this, what ultimately became a Supreme Court decision in Carter v. Canada, ruled that it was only meant to be an exceptional circumstance. The Minister of Justice of Canada said publicly that this was not supposed to be a substitute for all types of medical suffering, and as well as the lawyers that were represented the plaintiff in what eventually became the Supreme Court decision, told the Supreme Court that what they were asking for was a last resort, right? And I know people are joining from all across the world to this webinar. In jurisdictions that haven't legalized euthanasia yet, those are the same arguments that you hear all the time. You heard it in Australia, you heard it in New Zealand, you're hearing about it now in the United Kingdom. MAID is meant to be only exceptional. And this is a core part of the argument for legalizing assisted dying, right? Another term for this, which is it's only for those who have tried everything possible. That's as several Canadian cabinet ministers have described it. You've tried everything possible. There's nothing more medically more that a physician can do. So let's legalize euthanasia. That was the argument. Well, the problem with that is that when we see the data in Canada, we see that all of those factors no longer apply, right? And that if you look in terms of the leading causes of death in Canada in 2022, MAID now represents effectively tied as fifth, right? And part of the reason why I say effectively tied is that we don't actually know how many causes of death there are, right? Because the reporting mechanisms that are used in Canada obfuscate it, right? So normally it's Statistics Canada who reports on the leading causes of death annually. However, Statistics Canada does not consider MAID to be a death ever. And that also includes cases that since 2021, when Canada further expanded MAID, in 2016, it was supposed to be only for those that are terminal cases, right? And they also invented a new term for that, which was a natural death that is reasonably foreseeable. If you know what that means, tell a Canadian lawyer, because it's still unclear what exactly a natural death that is reasonably foreseeable. Wouldn't that just include old age? No one knows. Well, since Canada even went further beyond that vague term to natural death that is not reasonably foreseeable, Canadians are very descriptive people. Well, we've seen that people have qualified to die for MAID in cases where the underlying grievous and irremediable medical suffering that is causing the physical suffering were cases such as hearing loss. We've seen this with type 2 diabetes, we've seen this with arthritis, and we've seen this with a litany of medical conditions that ordinarily no one has ever died before from, right? Well, Statistics Canada does not consider any of those cases to be deaths by MAID, right? And instead, they, in those cases, theoretically, because we have no way of independently verifying this, the cause of death in those cases would be the underlying illness, which includes, in some cases, suicide. So someone attempts a suicide, fails, and then qualifies and dies through MAID. Their underlying illness was the suicide attempt. So I've written about that as well. It also includes then that case of hearing loss. We already had a documented case of that. Anyhow, but the point is that if you look at this data right now, Health Canada is the only one that reports on MAID deaths. Statistics Canada does not, right? So we don't actually know how many, for instance, cerebrovascular diseases ended up in MAID. You think that the annual reporting would be able to tell us this, but it doesn't, right? So there's an intentional, okay, I shouldn't say intentional, but there is an obfuscation that is happening between these different agencies. At the same time, different provinces in Canada, and Canada for the Americans among us, Canada is divided, it has provinces and territories, and they're the ones who are responsible for healthcare. Different provinces in Canada have different determinations over whether MAID is a cause of death, right? And in the largest provinces in Canada, MAID is not even mentioned on death certificates, right? So we have no independent way of verifying if the MAID reporting is accurate within those jurisdictions. But even with all those asterisks aside, right, what we see is that in 2022, more than 36 Canadians every single day died by the hands of their physicians or nurses, right? That is quadruple the official suicide rate, right? If you can see that intentional self-harm is all the way down there. And we've seen that MAID has quickly become from something that was meant to be exceptional and rare to one of the most common causes of death in Canada. There's not really that many more that would happen. We also know that in 2023, again, we don't have the MAID report out yet, but we know that in 2023, the number of deaths from COVID has dropped, right? So it's and we also know that the number of deaths from MAID is likely now around 15,000, as the Euthanasia Prevention Coalition has already reported. So it's very likely that MAID in 2023 has even went beyond being tied for fifth to now being fourth or third leading cause of death in Canada. That is exceptional, and Cardus created this beautiful graphic. I don't know if I can pause it, but if we see before MAID was legalized in Canada, that it was actually very rare for MAID to be such a high percentage of total deaths. We see that much older jurisdictions that have legalized assisted dying did so many decades prior, right? So Switzerland, for instance, they legalized it in the 1940s. Netherlands decriminalized it effectively in the 1980s. Belgium formally legalized it in 2003. And yet you have this new euthanasia program in a country that has never had a history of euthanasia. That was a core piece of evidence, by the way, in the Cardus decision, right? That we can't simply assume that that Canada, with its unique medico-legal history, is going to be similar to other jurisdictions that have legalized euthanasia. That's what Justice Lynn Smith, the trial judge in the Cardus decision, said. And yet, right after legalization, you have, one second, I'll go back. You have Canada quickly rising to become the second largest as a percentage of total deaths MAID program in the world. In terms of absolute deaths, it is the largest. It's honestly exceptional, and it's stunning. The fact that Canada is catching up with the Netherlands, right, who have already legalized it for over 40 years, is just stunning. It's also stunning that, for instance, Belgium, which legalized it just months after Netherlands formally legalized euthanasia, they have never managed to cross the 3% line of medically assisted deaths as a percentage of total deaths, right? Canada managed to do it in 6 years. The following year, it crossed the 4% line. It is exceptional, and yet there is absolutely no discussion prior to this report and amongst a few others, about this happening in Canada, right? You think that the alarms would have come from Health Canada, you think that it would come from different medical associations, right? If you had such a rapid increase in the number of suicides, you would assume that there would be some sort of discussion happening amongst whatever public bodies there would be. And this is just another way of showing this. For the Americans in the room, you can see that when Canada legalized, the first year that Canada legalized assisted dying, it already surpassed that of other jurisdictions in the US, right? So in the US, 10 states and the District of Columbia have legalized assisted suicide. Canada, in its first year, already passed the Oregon, which legalized it in the late 1990s. And it already surpassed Washington, which legalized it in 2009. As well, the other part in the data that you can see is that all of these jurisdictions have seen rapid growth in euthanasia. This is true in every single jurisdiction. There has never been a stable rate of growth, even though part of the evidence that was submitted to Cardus was that there was stable growth in those jurisdictions. If you zoom out far enough, you just don't see that. You see increased and continued growth, but especially in Canada. And answering that question, I think, is crucial for us to understand why is this happening in Canada and what makes Canada's MAID program so distinct from other euthanasia programs. I'll just play a video from the trial judge trial judge, excuse me, from the chief lawyer who was representing the plaintiff in Carter v. Canada, which was a Supreme Court decision that ultimately struck down Canada's blanket ban on euthanasia, and which Parliament then took to legalize and then expand euthanasia. I'll just read out the transcript, right? So what the chief lawyer for the plaintiffs in the Cardus decision, he said that in almost every single case that doctors' best interests are to ensure that their patients live, right? And that the reason that they were advocating for physician-assisted suicide was that physicians would always treat MAID as a last resort, which we just do not see. Part of the reason why we don't see this data isn't in front of you right now, but we can look at this from the percentage of total cases of explicit MAID requests that end in suicide. That was the terminology that the trial judge in the Carter decision used. We don't use suicide to describe MAID anymore in official bodies, but it is effectively what it is. Well, the evidence that was submitted in Carter was that only 10% of explicit requests for assisted suicide in Oregon ended with suicide through physician-assisted suicide. And in Netherlands, it was 30%. In Canada, in 2022, it is over 80%. And this seems to be the reason why Canada's MAID program has increased so rapidly. If Canada's euthanasia program still had the same percentage of explicit MAID requests that ended in an assisted suicide of only 10%, Canada's MAID program would be roughly on par with that of Washington State's, instead of becoming number 2 and on the path to replace number 1. No one, and I want to emphasize again, no adult in the room predicted that this was going to happen. Critics did not believe that this was going to happen. The trial judge in Carter didn't believe that it was going to happen. Health Canada, which is the only federal body that's responsible for overall review and monitoring of MAID nationally in Canada, didn't believe it was going to happen. And in fact, one of the parts of this report that is the first that I've seen is that this is the first time that any estimate from Health Canada has become part of the public domain. And the way that I found this was actually in the Canada Gazette, which is by law, all of these agencies have to report on the administrative burden of legalizing different programs and the administrative burden for MAID, right? Because it's going to cost physicians X amount of additional work. Well, as part of estimating that administrative burden, they also came up with, well, what are going to be the number of MAID deaths, right? Because they need something to multiply, right? If a physician is going to spend X amount of minutes, well, they need to know how many cases there are going to be. Well, in 2018, Health Canada came out in a report saying that Canada was going to reach a steady state in MAID deaths of 2%. And 4 years later, they doubled the estimate, saying that Canada was going to reach 4% of total deaths in 2033. Note that they made this estimate in 2022, right? So, which is when Canada already surpassed 4% of total deaths, right? So it's clear from this that Health Canada, even in the same year that it's making its prediction, had no idea what was happening with the total number of MAID deaths. I think this is concerning from an oversight point of view. I think it's concerning from a regulatory point of view. And I think it's just concerning in the total number of MAID deaths too, right? No one predicted that this was going to happen. At the same time, one of the things that's a little bit weird, so forgive me for using that word, I can't think of a better one, is that Health Canada, at the same time that they were making these predictions, were advising different things to the Minister of Health. One of the things that they advised was and this is from free information requests that I did, with asking for like the minutes of different cabinet ministers when cabinet ministers introduced Bill C-7, which expanded MAID in 2020, which came into effect in 2021. That expanded MAID for non-terminal illnesses. And part of the wording in the messages that Health Canada issued was, as expected, there's been consistent and gradual increase in MAID deaths over the last 3 years. Well, this isn't true, right? This is empirically not true, right? So I don't know if the staffers involved didn't know that Health Canada already issued public reports, right? The Canada Gazette is a part of the public reports, or I don't know. Yet they said it was as expected when Health Canada itself didn't expect this. Another element of all of this is that the median number of days between a request for MAID and death for MAID has declined precipitously in other jurisdictions, and in Canada, it's always been low since we've had data. So in Oregon, we've seen that the median number of days between request for assisted suicide and death from assisted suicide has dropped by over half between 2016 and 2022. And if you think about it, that's a dramatically quick turnaround in order to get a physician to make sure that their patient qualifies, to inform a patient about all available palliative treatments and medical treatments and disability supports, to get them consultations, et cetera, et cetera, et cetera. And yet this is from the request for a MAID death, and actually receiving it, right, is under 30 days. I think it's very difficult for people in Oregon to receive, specialist medical care within that time frame. Well, in Canada, it's always been shorter since we've had data. We have data in Quebec, which shows that it was always around 11 days. In 2021, when you see the decline from 11 days to 9 days, that was because a federal bill, so as part of Bill C-7, it actually removed some of the safeguards. One of the safeguards was that there had to be a minimum 10-day reflection period. If you know what that means, good. Parliament doesn't like to define things with MAID. But this reflection period could have been waived prior to this, which is probably what we've seen in the data before. And we've also seen from independent studies that this was indeed waived in most cases. Or sorry, I shouldn't say in most cases. In some cases, it was waived. I think it was around like 30%, but I'll need to double check on that. But in 2021, they removed that reflection period altogether. Canada nationally started reporting on this data in 2021 and 2022, and we see that it's almost identical to the Quebec data. This also means that you can now have same-day MAID request and same-day MAID provision, and we do indeed know that this is happening. We just don't have any data about the frequency that this is happening. And it's also worth pointing out that this includes people with track 2 cases. So that's people with a non-terminal illness. The median, so we don't know the number of median days that it takes for them to request, but presumably it's much larger because in Canada, if you qualify under non-terminal illness, you have to have a 90-day assessment period, a minimum 90-day assessment period. So this is just shocking. It's very difficult to see in Canada that dramatic rapid turnaround for most medical requests. We've seen that wait times in Canada have increased precipitously at the time, like since before MAID was legalized. Canada has the longest wait times it's ever had, according to the Fraser Health, according to the Canadian Institute of Health Information. We just see, even for non-elective medical treatments, so the index that the Canadian Health Institute, the CIHI, the Canadian Institute of Health Information, they issue an index for the number of days it takes from when a patient, or a physician, I should say, requests for a patient a necessary medical treatment to when they actually receive it, and their index is closer to around 30 days. On average, based off their criteria of what qualifies as an essential medical treatment. right? So you can access and receive MAID much quicker than necessary medical procedures, right? And this is in discussing elective medical procedures or assisted living, which in some cases can be up to over a year and a half in Canada. And I think that concludes the PowerPoint. I believe there are questions. Alex, I don't know if you want to just read if people submitted questions. I haven't seen the.
Well, what I was going to do first is make a couple comments, because one of the things that makes Canada different, you pointed out very clearly that in the court, it was discussed about the fact that there would be this would be considered a last resort, but in fact, it never was in the legislation put down as a last resort, nor was it interpreted that way. There's a couple reasons for it, and I don't know if I have to get too deep into it, but what happens in Canada is the argument is that you can't force anybody to accept medical treatment, but that would be no different than the Netherlands. You can't force anybody in the Netherlands to accept medical treatment either. The difference is that in the Netherlands, MAID, which I'm not saying is anything good in the Netherlands either, euthanasia in the Netherlands is considered a last resort, whereas in Canada, you can have a treatable medical condition, but so long as you have a grievous and irremediable medical condition and you're over the age of 18 and you're capable of consenting, et cetera, you can be killed if the doctor is willing to do it. And that's exactly why we have what we have. The other thing about it is you mentioned about, of course, 2021, the waiting period got changed. In fact, that it got the 10-day waiting period got removed. Previous to that, the 10-day waiting period was already able to be waived, as you mentioned. So you already had a certain percentage, as you already mentioned, deaths that were occurring very quickly. And so that the only difference now is there is no waiting period if you're considered terminally ill. But if you're not considered terminally ill, there's a 90-day waiting period. But I'm personally very concerned. I think there should be a lot of research done into this, but the problem is everything's considered privacy, so it'd be hard to do this research. How many of these type 1 cases are actually people who should have a 90-day waiting period? It would be very hard to determine that because of how the reporting system works. Nonetheless, I thought I'd throw that at you.
Yeah, it's also, I completely agree with you. It's also important to stress that in the trial decision, and the reason why I keep coming, so let me just rewind a bit. The reason I'm coming back to the trial decision is that in any sort of English-based legal system, we first have trial decisions, right, that determine the facts of a case, right? And in appeal, there's questions over the law, right? And if it's appealed again, then it goes to the Supreme Court, right? So in Carter v. Canada, the Supreme Court decision, right, they essentially, there were almost no new facts that were added at the Supreme Court stage, right? It's actually very rare. So all that the Supreme Court did was essentially review the legal case that the trial judge determined, right? And the trial judge determined that there needed to be an end to a blanket ban on euthanasia.
Right, Justice Lynn Smith, was the judge at the lower court. Yes.
So part of the explicit argument that Justice Lynn Smith did was in order to show that vulnerable patients who would otherwise have vacillated on their suicide requests, right? We know that patients, especially end of life, have a desire to die. Frequently, that's one of the most common symptoms of patients at end of life. Justice Lynn Smith ruled that there needed to be some time between a MAID request and a MAID completion, right? And because that existed in all of these jurisdictions that she reviewed, and again, she herself did not review them, this was just evidence submitted of Oregon and the Netherlands in studies that are actually pretty shaky, but let's just ignore that, right? Even if you assume that, her analysis was correct, right, and that this was capable of protecting patients at end of life, because there would be some time between a request for MAID and dying for MAID, qualifying and then dying for MAID, this no longer applies in Canada.
Yep.
right? So, and this is just a dramatic turnaround in such a short time, right? This decision, you know, the Supreme Court decision was in 2015, right? Never in the history of any voluntary euthanasia program has there been such a rapid turnaround. And there's a million and one reasons why that could be, or let's say guesses why that could be. But it's important to start there, right? That there is something qualitatively different about Canada's euthanasia program compared to other euthanasia programs.
Yes.
And the evidence that was submitted to the trial judge simply does not hold up with what Canada's euthanasia system is right now.
I think I agree completely with everything you said, especially since the fact that we do view it differently. And I know anybody wants to ask a question, they could put their hand up, and I will go to them. I know Rebecca might have a point to make in 1 second. I will say that one of the things that made Canada different is that we have two laws. We have a Quebec law and we have a federal law, and they're actually a little different. So Quebec, which all the Americans and Europeans on the call might be thinking, how can you have two laws in the same country? The Quebec law came first, and they did so because provinces control healthcare in Canada, and the federal government controls the criminal code. So therefore, Quebec legalized euthanasia by declaring it was a medical treatment, whereas the federal government, what it did is it created an exception to homicide in the criminal code to allow for euthanasia. So, and actually Alex made a comment earlier about it being suicide. In the US, you have assisted suicide, which would be clearly a form of suicide. Euthanasia is actually a form of homicide because someone's actually killing you. I'm not saying assisted suicide isn't similar, it's nearly identical, but clearly with euthanasia, the doctor or nurse practitioner is killing you. That's homicide. Nonetheless, we get back to it. So Quebec called it medical treatment. That did affect the rest of Canada, even though the rest of Canada, this is an exception to homicide in the criminal code. It's just confusing, but that's what it is. Alex might want to comment, and I know Kevin's got his hand up, and he's in the UK fighting the euthanasia law. Go on,
Yes.
Alex.
Yeah, no, I just wanted to, I think I spoke enough. Rebecca, did you want to mention something?
I just thought it would be interesting to underline some of the data aspects, because as we were working on publishing this, something that really was underlined for me was the complexities of working with these data sets. And as you mentioned, sort of the differences between different bodies and sort of the lack of centralization of some of the data, the lack of how we're categorizing this. And I remember having many conversations with Alexander and our VP of research as well about the many footnotes and need for more footnotes. And then, well, now we have too many footnotes. Now the report is half footnotes, because trying to provide a level of transparency on how the calculations are being made, what sources these are coming from, is really challenging when you have these disparities in terms of how data is collected, and disparities in terms of the categorization. I don't know if Alexander, you want to say any more on that, but that was, I think, sort of in the editing role, was one of the biggest challenges, was that level of complexity, and how do you communicate that in a responsible, transparent way?
Yes.
So I want to comment on that for 1 second. I'll go to Alexander. The reason is that I've done a lot of research on that very question, because I've been collecting, I collected the 2022 data before the federal government released it, and I've collected most of the 2023 data ahead of time, because it's all the provinces that collect that data, and then they submit it to the federal government. So each province is different. Each province's data set is different. Some of them have far more information than others. Like the Quebec data is far more complete than the rest of Canada. And this is just a reality. So it's hard even in many ways to compare apples to the oranges. So let's say the oranges are Ontario and apples are British Columbia. It's hard to compare the two because the data sets are so very different in how they collect it. But I'll let Alex go, because he's obviously the guy who's supposed to be talking.
Yeah, no, Alex and Alexander. Yeah, so I completely agree. Part of it is that the data reporting mechanisms have been obfuscated. This is because there are multiple agencies involved. At the same time that this is healthcare in Canada is a provincial jurisdiction, while it's a criminal, which is a federal exemption in the code. In theory, it is the Minister of Justice and Attorney General who's responsible to make sure that Canada's federal criminal code is being followed. However, the Minister of Justice explicitly, in a statement, said that he's not doing it. And instead, it's only going to be provinces that are going to be reviewing to ensure that the federal criminal code is being followed. This is an abdication of duty. I don't know of any other section of the criminal code where the Minister of Justice said that I'm not looking into it, even if the law is potentially broken. That's one of the reasons why it's difficult. And if the federal government did a better job at collecting all this data, right? If the data that we have, which again only comes from MAID providers and assessors who submit reports, right? So we don't have any independent data, right? The exact same physicians and nurse practitioners who could potentially face criminal punishments, none of them ever did, but any of them who could potentially potential criminal punishment are the same people who are then reporting the MAID deaths in Canada. And these are also the same people who then, and if you look at like the Health Canada reports, right, that something like a third of all MAID deaths in Canada were from patients who felt that they are a burden to themselves, their families, and their caregivers, right? These are from the data that we have comes from the MAID providers, right? So these are MAID providers who are assessing their patient as feeling like they're a burden, qualifying them eligible, and then ending their lives, right? So the problems that we have with this data is just shocking. And you don't even need to be a critic of Canada's MAID program to realize that there really are commonsensical approaches to ensure public safety, which is something that even MAID providers, like the Canadian Association of MAID Assessors and Providers, issued public reports saying that there needs to be accountability in the few cases where MAID deaths are not followed.
So Kevin has a question, so we're going to go to him because he was first, and then it's Jackie, and then Charbel. But I'm just going to make one comment before Kevin starts. Sorry, Kevin. I'm just going to say that you can't actually prosecute under Canada's law. It's not possible. The reason is that in the law it says that the doctor or nurse practitioner only have to be of the opinion you fit the criteria of the law. Well, I'm of lots of opinions. It's impossible to prosecute me for my opinions. We'll go to Kevin. Now, Kevin should introduce himself because he's pretty important what he's doing in the UK right now. So Kevin, unmute yourself.
My name is Professor Kevin Ewell, and I am the head of Humanists Against Assisted Suicide and Euthanasia. And we are fighting things in the UK. We are desperately fighting a Scottish bill that's been proposed, and we're also fighting legislation. There's another bill in the House of Lords in the UK at the moment, and I think, unfortunately, that Jersey has pretty well past its law. So it's a bit of a disastrous situation in Jersey and the Isle of Man. But we're still fighting, and we have a lot of faith that we can actually defeat this in the UK. One of the reasons is because of Canada, which talk about a silver lining to some pretty horrific things that are going on. People are horrified by the Canadian examples when we present them. The number of people who I've spoken to have said, oh my goodness, how can you actually, I actually supported this before I heard about these cases from Canada. And one of the questions that I have, I suppose, is that those who are in favor of euthanasia in Canada, and 99.9% of it is, of course, euthanasia rather than assisted suicide, though both are legal. One of the questions, I have a couple of questions about it. First of all, it seems that there are a few people, and I have clashes with somebody called James Downar and other people, and they seem so unself-aware. So it's like nobody has challenged them. They seem to have a total free rein, and they push things and push things and push things. And this is one of the shocking things. I think there's Alex and a few other people who are fighting back, and not many other people are even questioning it. And I wonder why Canada is like that. My second question is that is the mental health case going through at the moment a sort of another attempt to actually push to to do what the government is too cowardly to do, which is actually to have a democratic decision about this. It appears that the courts are not really dictating, but the government is saying, oh, well, the courts have said so, we can't do anything. Of course, I don't understand a lot about Canadian law, but there is a couple of, isn't the notwithstanding clause important in being able to actually overcome the
So
decision of the
Kevin, you're
courts?
referring to the recent Dying with Dignity court challenge that's begun to force
That's right,
euthanasia
yes.
for mental. Yeah.
Do you know the name of that? Because I was trying to recall that, but I can't remember who is doing it. But it just seems
Dying with
another
Dignity. Yeah.
but it's another stalking horse, which is going to force the government to do what it's put off a couple of times, which is institute euthanasia for mental health. So yeah, I will. That's just my brief question. The only other thing is to say, unfortunately, Canada is the future, not not an outlier so much. So if you look at Spain and the way that they have structured their legislation, it's very similar to Canada. It was proposed in Jersey, although the track two was defeated. It was still really an essential feature of the whole discussion there. So why is Canada the future of this, and who are these people that are launching this assault on what it means to be a human being?
Right.
So Alexander, Kevin gave you 3 questions. Way you go.
So I'll first start that Canada is the future of this, but we see similar problems in the United States. We've seen cases. So, for instance, we only found out that patients of eating disorders have been qualifying and dying from assisted suicide because a U.S. physician wrote a case study of it in 2022. Well, a year prior, in Parliament, a psychiatrist testified that he was involved in a case where a young woman with anorexia qualified and died from MAID. Even before Canada expanded it to non-terminal illnesses. And we see similar problems in the United States too, right? 10%. So in 2022, the last year that we have data, Washington State, 10% of all MAID deaths were by patients who, according to their MAID providers, believed that they had that the cause of their suffering was at least in part because of financial concerns of treatment. In Oregon, it was around 6%. These are exceptional facts, right? That the true number of patients who are being pressured into an assisted suicide because of lack of financial support in the United States is essentially an epidemic, right? It's difficult to see any other form of medical diagnosis. And we also know that MAID is not a form of medicine, despite it being clad by this, right? That this is suicide facilitation for people who are disabled. Instead of suicide prevention, right? So we know that there's an uneven and unequal application of suicide prevention. We know that this impacts certain vulnerable groups more than others, especially people with disabilities, especially people who are older, especially people with eating disorders, especially people with psychiatric illnesses, right? So we just see that in the data everywhere. I'm actually writing I'm working on a book right now mostly about the problems of assisted suicide in the US. So if I haven't spoken, I've seen that I've spoken to many of you, but if I haven't spoken to you and you're interested in talking to me about that, feel free to email me at araikin@eppc.org. But that's another story. Now, to answer your questions more specifically, first, the case of James Downer is just bizarre. There's a term in Judaism called Lashon Hara, so I'm going to avoid speaking ill about him. But I don't understand him. I don't understand. I just don't understand. I had an interesting discussion with him about. He gave a webinar that I listened to about the cases of lack of compliance in Quebec, right? So Quebec every single year issues an annual report, and then they have statistics about the number of people who, according to the review board, should not have qualified. There's been over 129 cases where they found people who should not have qualified. either because they didn't fit the MAID requirements, procedural safeguards weren't followed, the patients couldn't even qualify, right? So in the most recent year, there's been a surge about cases where they didn't even have a grievous and irremediable medical suffering. And in about a dozen of those cases, there was no even theoretical illness or disability that could have even qualified them, right? So if you look in Quebec's most recent annual fiscal report, there's a new category when they list the different illnesses and disabilities that qualified people for MAID, because in Quebec, there's now a new category with no illness or disability that would have qualified under Quebec's law. Despite this, James Downer was giving a presentation where he said that these were only cases of missing signatures, which is just categorically untrue. And I messaged him saying, hey, what are you talking about? Look at this report. And then he said I couldn't speak French. So that was my conversation with him. I don't understand. He is part of the editorial of like the Journal of Palliative Medicine in Canada. He issued an editorial with some other MAID providers about how palliative care is always being accessed. And there's nothing to worry about because, look, a majority of MAID patients, people who die in MAID, according to Health Canada, receive palliative care. That doesn't really answer the underlying question, which is, are the right people accessing palliative care before they can access MAID, right? Are they receiving an adequate level of timely palliative care, right? And we actually have seen by different chart reviews already published in Canadian medical journals, and I can send these to you afterwards. That's part of the second report that Rebecca was talking about earlier, which I feel really bad for her because the report right now is 20,000 words. So this is my way of apologizing. But if you're interested, I can send you those different chart reviews. And I found like 4 or 5 different chart reviews that show that people who die from MAID frequently access palliative care too late. There was one chart review about a series of about 2 Quebec hospitals and an assisted living home. It found that 50% of people who died from MAID only accessed palliative care 5 days prior or 5 days after their MAID application, right? So and we also know that most Canadians, do not receive adequate palliative care, right? And this is true for MAID deaths as well. And yet, despite this, again, this is documented. This is part of the academic literature. None of those studies wound their way up in the editorial in the Canadian Journal of Palliative Medicine. I can't explain it. I can't explain it. And for your second question, which was on the mental health care and about dying within in Canada pushing this, it's important to stress that there was no legal requirement anywhere for Canada to even pass a bill to expand MAID for mental illnesses, right? This wasn't a judicial decision, right? The judicial decision was a lower court that told Canada that, hey, you have to expand MAID for non-terminal illnesses because otherwise it's discrimination. The government of Canada chose not to appeal it, even though virtually every single prominent disability organization in Canada urged the government of Canada to appeal that decision. They chose not to do it, and they didn't appeal it whatsoever. They didn't even appeal it to an appeal court of Quebec, right? They just chose to do nothing, right? They chose to accept it. And when that was being debated in Parliament, you had a senator, his name is Dan Kutcher, file a last-minute amendment at the last possible reading of the bill to expand it as well to mental illnesses, right? So there was no even a rubber stamp of judicial imposition about this is happening, right? This was, I don't think that there are coincidences in politics, right? The fact that this happened without any public debate, the fact that it happened so suddenly, the fact that there wasn't any prior public discussion and it contradicted the government's position on euthanasia, and yet this is how it became part of the law, right? So the fact that there is a court case now, I think it was going to happen regardless. I think the facts on the ground are very poor. Canadians do not have a problem with accessing timely MAID care, right? They have a problem with accessing timely medical care and palliative care.
So I promised Jackie she'd be next, so she's going to be next. And as I said, Charbel is after Jackie, and Gordon, who's the president of EPC, is going to be last. So Jackie, you can unmute.
Thank you. Good afternoon, everybody. Hello, Alex. Hello, Alex, and hello, Alex. A couple of questions rolled into one. Do you have a sense of why MAID is not listed as the cause of death? And specifically, my area is Ontario. So when I saw the change in the coroner's office from 2016 to 2018, to be honest, I hadn't picked that up. So that has surprised me. And then this discrepancy between Health Canada and Statistics Canada. You explain that? I mean, I just don't understand. I know they're different departments. I get that. And in answer at the beginning, you said nobody knew that we were going to go this way. I think most of us on this side of the fence knew it, but we're not in positions of power. And then, sorry, but lastly, anything in your research that showed numbers of euthanasia organ transplant? Because I was on a webinar with Dr. Downer that had my blood run cold regarding that. So sorry, it's a few.
Yes. Yeah, no, I actually wrote a long form article that I haven't published yet on organ donation after euthanasia. So I actually do have the statistics inside of Ontario, even though they haven't been reported. It is rarer than they expected. So I think that's probably the reason why it hasn't been published yet. But it is, I don't have the exact statistic in front of me right now, but it has happened dozens of times in Ontario. Ontario was supposed to report it. They chose not to do so. I don't know why they haven't reported it, probably because of the concerns. Again, the fact that we're talking about James Downer is because James Downer was head of the team by Canadian Blood Services for their organ donation policy on euthanasia and withdrawal of life-sustaining medical treatment. They grouped it together to make it seem that this is being done on a sort of equitable fashion. In reality, it wasn't. Ontario was the first jurisdiction anywhere to solicit organ donation from euthanasia applicants, even before they qualified for MAID. Right, so it was at the time it was after their first MAID approval, right? But in Canada, you need to have 2 MAID approvals, right?
Mm-hmm.
They could have waited until after the second MAID approval. That's what the Netherlands does. That's what Belgium does. Instead, they have a policy where they solicit organ donations from all MAID applicants after their first MAID approval. And they're happy about it. I have a webinar from the chief medical officer for Ontario Trillium Gift of Life Network, which is the organization responsible. And he was talking about how the reason that they implemented that change was because he had a webinar call with Ephesus, and in half an hour they all decided that this was a great policy to have. And he was saying that, oh, well, look, if I can get Ephesus to agree in half an hour, then that means that this is an unassailable policy. I would argue the converse. I think that this shows that the people in charge of these policies are not open for any criticisms, especially from disability organizations, especially from people with psychiatric illnesses, and from other vulnerable groups. So there's a great report that came out recently by Catherine Frazee in the Canadian Journal of Disability Studies. If you can't find it, send me an email and I'll send it to you. Where she collected all of these stories of by disability organizations and people with disabilities warning the government of Canada what was going to happen once MAID was legalized and expanded, and that no one listened to, and their predictions were completely on par with what happened. So that's part of that. The other question you asked is why do Health Canada and Statistics Canada have different policies? I don't know. I don't know. You would think that Statistics Canada would take Health Canada's lead. Right? So Health Canada actually has a policy on death certificates. They urge all provinces to implement MAID as an immediate cause of death, right, on death certificates. So you think that it would be reported in the data, but they don't. So MAID has become, from even the way that we describe it, right, what MAID activists want and advocates have been trying to push, is that MAID is only a mechanism of death, right? So the same way that you can be declared brain dead, or you can have a cardiovascular cessation, they want MAID to be considered a mechanism of death. That is the argument that James Downer did in why MAID, why you should solicit all euthanasia applicants for organ donation, is because MAID is not a cause of death; it's a mechanism for death. It is bizarre. No, I don't know any other jurisdiction that has similar policies to that. I think this is part of an ongoing push. I don't want to impugn unnecessarily, so I'll keep some of my private commentary to myself. But it is just bizarre. James Downer has been such an activist for MAID. Ironically, he works for a Catholic hospital. And yet he also was impugning Cardus as a Canadian Catholic organization, which it isn't. Cardus is a Christian organization, but this was not I'm not Christian. This is not a theological policy, and I don't see how someone's personal identity would impact the facts of the ground. So I don't know, to answer your question.
Okay.
Are you
Thank
saying Kevin Yull doesn't work for a Christian organization? I'm just teasing Kevin. Sharp. I just say that because he's the humanist against assisted suicide euthanasia. So, Charbel, you're next.
Yes, I
That's
have
right.
questions. Multiple questions. I can summarize it. Well, MAID. The question about MAID and euthanasia, but isn't it MAID considered accessory to homicide by euthanasia? We all run by the common law in the Commonwealth country. Isn't it this considered legal heresy when you are changing the term of euthanasia to MAID? Because it's still accessory to murder if you consider euthanasia murder. The second question, Alex, is the Canadian criminal code still consider euthanasia as a homicide? Yes or no? Because I think this is the fine line. They tricked us. It's a heresy. I mean, whatever you call it legally, they changed euthanasia to MAID, was actually still accessory to euthanasia. Isn't it that true, Alex?
Yes.
I mean,
Yes.
if you speak about it.
Yes. So to be completely clear, right? Euthanasia and assisted suicide in Canada is only legal through a criminal exemption in the criminal code, right? So it is the act of MAID. You can define however you want. You can use whatever terminology that you want. You can call it an assisted dying. You can call it an assisted suicide, euthanasia, medical assistance in dying, whatever term you use. Under Canada's criminal code, it is an exemption to homicide and an exemption to aiding suicide, right? So these are still, that's the legal reason. The exemption is only for physicians and nurse practitioners who follow each of the safeguards that are listed in the criminal code, as well as also following the reporting requirements, right? So if a physician or nurse practitioner doesn't follow these codes, any part of these codes, and as well as there are provincial guidelines too, and that's also included in the criminal code, right? So you have to follow the federal legal criminal code safeguards and the provincial policy safeguards. And if any part of those policies you do not follow, you can face up to 14 years in jail for a culpable homicide. No physician or nurse practitioner in Canada has ever faced anything similar to that, but that is what MAID providers and assessors are saying. And part of the reason is that it's in all jurisdictions that have legalized assisted dying or euthanasia, it's always been extremely difficult to prosecute those cases, even in egregious examples where a MAID provider or a physician has ended the life of a patient. We've seen this in, I mean, we've seen this in the United States with Jack Kevorkian, right? He had to literally go on a national television and euthanize a patient in order for him to be even be arrested. So there's a long history in the United States and in Canada and in the UK for eugenic euthanasia, even as these policies are part of the criminal code. The first example in the US was in 1915 with a doctor named Harry Haselden, who would write multiple newspaper accounts of what he did. And he would even create a feature film in 1917, I believe, which is actually stored in the Library of Congress, right? So this happens even when euthanasia is not legal. These physicians should clearly be prosecuted. Jack Kevorkian killed not just patients who are terminally ill, but he also killed or assisted the killing of patients who were not terminally ill. Many of them had depression. He was not an expert. He was perverse in a way that is difficult to even quantify, right? His personal views were abhorrent. He was a forensic pathologist. He didn't have any expertise with treating patients with depression. And yet, he would literally have to kill someone on camera and film it nationally for him to even face prosecution. And part of that is that in the judicial system, certain lives are devalued. I think that's important to fight back against. But once you've legalized euthanasia and assisted suicide, that's when the barn door opens, right? And all of those which were previously rare cases become an epidemic.
Okay, last but not least, Gordon Friesen. He is the president of EPC, so he should always get the last word, if not the first word. Thank you, Gordon. Now remember, we're at 3:04, so let's ask the question. Get rolling.
Yeah.
Very good.
Okay, but I think these things always close too early because we just get down to the meat at the end of the meeting. Anyway, Alexander, I just absolutely want to congratulate you on the wonderful work that you're doing, Kevin, as well. But Alexander, you managed to publish some things that really had to be published. But I would like to suggest a point, a misunderstanding that it seems to me people keep having about this is why it's happening. And it's because in Quebec, euthanasia was defined explicitly as a medical treatment. Okay, that's why they don't have a legal problem. That's why they can do things without going through the courts. It's because, the World Health Organization, healthcare is a human right. Providing healthcare is a state obligation. Now, you can say it's not healthcare, it is healthcare. Quebec defined it as healthcare. And because they have a complete monopoly control over the health system, what they say means something, and all doctors and all nurses and everybody has to. So just clearing up a few things. Cause of death. Why would MAID be listed as a cause of death? We don't list an accidental morphine overdose when you're treating cancer as a cause of death. It's not. The morphine is a treatment for cancer. You see, MAID is a treatment for suffering. Okay, so because it's a treatment for suffering, of course, it's not going to be. You're not going to say that the treatment that failed is the cause of death. That's number one. Same remark applies to mental illness. Mental illness is a slam dunk. It doesn't have to go in front of the courts. Ultimately, eventually, any province could just simply say they were going to do it. It's impossible, for instance, that Canada is going to prevent Quebec from doing euthanasia for advance request, for instance. It will still be illegal under the criminal code. It'll still be homicide. But this Canadian government would not dare interfere. You see, this is the first thing. This is how this happened. Quebec defined it as medical care explicitly in order to defy the federal government. Because at that time, the federal government had no interest in legalizing MAID. So Quebec said it's not homicide, it is a medical treatment. And it began there, okay? So mental illness is a slam dunk. it's a treatment for suffering. People with mental illness are suffering. You don't have to prove that in front of the courts. A doctor just has to do it. He said, I was treating him for suffering using a well-known, well-established, clear medical treatment. Okay. Basically, the whole problem that we're having comes down to a confusion in the justification of MAID, okay? Because MAID as a medical treatment, you go into medicine, what are the justifications? The justifications are autonomy and beneficence, okay? Everybody's worried about how many people are going to be eligible for MAID and they can ask for MAID. We don't have a problem with autonomy. Autonomy, well, it's a problem, okay? But autonomy levels out. Like in Switzerland, almost anybody can get assisted suicide. But they have leveled out at 1.5%. Whereas in Quebec, we're up to 7%. Okay, so this doesn't have anything to do with autonomy now. Okay, the point is that the beneficence, in French it's beneficence, justification is that objectively speaking, as a medical proposition, in certain clinical conditions, a certain remedy is indicated objectively. Well, they've defined MAID that way. So now they're applying that definition in that way. Okay, so that the entire Quebec medical system now is a vast marketing program to push MAID. Okay, but it's on the level of a medical treatment, and it's on the basis of this idea that all of the patients who are suffering are better off dead. Now, I'm not going to go into the handicapped arguments. I'm handicapped. All right, I'm not going to go into the disabled arguments. It's the idea is that the cancer patient, the person with multiple sclerosis, all of these people are better off dead. If you're suffering, if you hurt, if you're mentally ill, whatever your reason is, you're suffering, you're better off. This is a treatment. This is a cure for your suffering. Okay, and it has nothing to do with the criminal code. It's a medical proposition in Canada, and that's why Canada is distinct. That's why Canada is different. And then when we get to, well, okay, basically we've come full circle from Nuremberg, because in Nuremberg it was stated that you cannot kill somebody to take away their suffering. That is not the right thing. Okay, so now we've come full circle on Nuremberg without admitting it. Now we've reversed that. We're saying, yes, there is such a thing as suffering, and death is a treatment for suffering. And as for the United States, the problem with the United States, they don't have the explicit medical definition, but they're weaseling the definition in. And this is the most important thing. The most important thing in the United States is not eligibility criteria. Okay, it's not whether or not you have euthanasia, whether or not you have a self-ingestion. Those are not the most important things. Those are very important things, but they are downstream from the medical definition. Because if you define it as a medical treatment, then automatically you will have euthanasia, because there's no difference between a doctor giving you penicillin by mouth or giving you an injection. It's the same thing. And as for eligibility will obviously open up as soon as the medical definition is accepted. So what people should be fighting in the United States is not eligibility criteria and well, go for it, fight everything at the same time. But the most important thing is weaseling in the medical definition. And they are doing that in very specific ways. They're doing that with the name, medical assistance in dying, but they're also doing it with assisted suicide. If we had free assisted suicide like in Switzerland, there are no mandates. Okay, so every mandate which is introduced in the United States is a suggestion that there is a medical legitimacy. And what they're doing is they're establishing kind of a mosaic, which is slowly coming into focus. And one day you're going to wake up and it's going to be an established medical practice. Okay, and that is the point where you're going to go past the tipping point into where Canada is right now. But just a last example of this is the state of Oregon. When Oregon has the most minimalist legislation. They don't talk about it. They had no mandates, no duties, no nothing. But when they removed the residency requirement, they did it because they said that the state has a duty to provide health care. We cannot deny health care to out-of-state residents. So they are establishing a mandate which is based upon a justification that they don't have in order to retroactively create the justification. That's what you're faced with in the United States, is that they are slowly converting this from a justification by autonomy, I want to die, to a justification by beneficence, you should be dead.
Yeah, I completely agree. So I'll mention just two quick things, if it's okay with Alex.
He's okay.
Okay, he's okay. I guess you guys can all just zoom out. Two quick things. The first of all is the out-of-state element about this is important, right? Now that residency requirements are now being phased out of all of the jurisdictions that have legalized suicide in the US. Some of them have already done this. Some of them are planning to do this. Other ones are, on the way of doing it. We are in a situation where we already have a documented case where a patient with anorexia in a state that did not legalize assisted suicide had a telehealth meeting with Jennifer Gudiani, who's an eating disorder specialist. She practices in 48 states. And she found that patient eligible. That patient traveled to her clinic, and she prescribed assisted suicide, right? So we already are at that point. We are hopefully going to see a pushback. I think that if you are in a red state in the US, things like what West Virginia is doing right now, which with the referendum against euthanasia and assisted suicide, I think that is crucial. If you have a constitutional protection for equal rights, I think that's a crucial step. At the same time, for other states, if you're in a blue state, right, pushing back against legalizing assisted suicide, we know that, we know this with suicide prevention, right? The more barriers you have for suicide prevention, the fewer total suicides there are. I interviewed a psychiatrist who told me that one of the facts that he found most interesting was that there are studies about jumping in front of about the number of suicides at different train tracks. And putting up a fence decreased total suicides, not just in that area, but overall in that city. And I think that if we truly want to live in a world where people have equal protections from suicide, where we do not promote suicide for certain illnesses or for certain disabilities, then that is an approach that we should take, right? I think we're all incrementalists now, and I think that's a great step. The other part I just want to say just very quickly, one of the things that I don't usually say publicly, but I think it's worth emphasizing, is that the comparison between Nazi Germany and Canada is obviously untrue for almost all cases. The one exception is not what happened after 1939, right? If you actually look in the history of Nazi Germany, two of the very first policies that they pushed through the Reichstag was a sterilization bill in 1930. So in 1933, after the Nazis ended up seizing control of the Reichstag, they pushed two policies, right? The first one was a sterilization bill that ultimately passed. And you had forced sterilization in Nazi Germany. It was modeled off of the United States. That's important to emphasize. And then the second one was an assisted suicide bill. In many ways, it had more safeguards than the current system that we have in Canada. It required a panel. There had to be at least 3 physicians that were on board. The request had to come from the patient, and physicians couldn't couldn't ask the patient about it. And yet, because of opposition from the German public in 1933, that was not passed, right? So I think what ultimately happened with the T4 action program, that was retroactively postdated to September 1st, 1939. That was a wartime measure, right? So the actual euthanasia program involuntary euthanasia program that happened in Nazi Germany, that only happened after September 1st, 1939, right, under the cover of the World War. And it stopped, right? Part of the reason it stopped was the Nazis were killing people left and right, and they didn't need to have this program. But also part of it was there was pushback. That was the only mass killing in Nazi Germany that there was pushback from the German public. All of this is to say, right, that the connection, the Nazi connection is not 1939, it's 1933. And I think that there's a lot to discuss over what it is that the German public in 1933 were opposed to that now in Canada we are discussing, right? Like, look, I am Jewish. This obviously is a connection that has a lot of personal connections. But I think we need to have a serious conversation, right? We're a nuanced conversation where we can discuss what happens when we devalue certain lives. Some people who are having this conversation were Katrin Frazee. I'm a huge fan of hers. She wrote a report about this, warning about the potential, and she was almost censored for it. I'm blanking on his name. Maybe Alex can remind me, but there was the head of the Canadian Medical Academies, one of the heads of the committees. He made a public connection warning about, linking with the T4 action program with what potentially could happen in Canada. And even that very nuanced description, he was forced out of his role. And he was then replaced with a pro-MAID advocate. So, yes, I think hopefully that answers your question, but I'll leave it to Alex or Rebecca if they want to say anything.
Okay, you're referring to the guy who left because he was part of that one committee that was looking at MAID with the it was Canada's what do you call it, the research arm that was doing that, and yeah, he was attacked for making a comparison to Nazi Germany. Absolutely. I think that it's 3:19, so I think we should go into a conclusion. So does anything left for Alex to say? This has been recorded, so it will be shared, and it will be it'll be on the YouTube page, etc., in the future too, so people can see it again. So I really think this has been an excellent event for all of us. So someone's asking again about terminal anorexia and terminology. Terminology does shift. That's exactly the point that's being made, that terminology shifts and that has new meanings. And we could have a whole talk about that too. As you know, Kevin, you all would know that one well. Yes, Gordon, you want to say something? Yes.
Just one. I mean, the thing is, the Nazi Germany thing is really subtle, and so it's important. There's euthanasia, there's involuntary euthanasia, and there's non-voluntary euthanasia. Okay, and let us say that Canadians would not go so far as involuntary euthanasia. But all they need is consent, okay? First of all, the doctor can suggest all they need is consent. But we have those two other categories. We have non-voluntary euthanasia. Now, if you look at the German thing, some people, the Germans say, someday we're going to have to settle down and realize what really happened in history, that the Germans were at the fine point of every culture and science, and that the United States was fully on board, and that Britain was fully on board, and then suddenly the whole human Western society hit a brick wall. Okay, sooner or later we're going to have to start analyzing it like that. But in any case, they believed that death was a treatment for suffering. And that is what we are now doing. Now we take death as a treatment for suffering. Now, in Canada, perhaps we will not have involuntary euthanasia. But it would be ridiculous to imagine that we will not have non-voluntary euthanasia. In fact, we already have the things that are on the table are infanticide, by advance request, and mental illness. All of these are, especially infanticide, are non-voluntary euthanasia. So you're looking at the potential liquidation of the entire dependent, incapable population. And that is in German territory without saying, oh, we're not Nazis. No, we're not Nazis. And no, we're not killing people and we're not sending people off to death camps. But we could be liquidating the entire dependent, incapable population.
Well, I mean, it's important to stress that we already do have a form of non-voluntary euthanasia in Canada right now. where part of the 2021 bill that expanded euthanasia in Canada removed safeguards. One of the safeguards that was removed is that no longer in all MAID cases, you needed to have final consent before a patient would die from euthanasia, right? So
but that's a detail. That's a detail,
well,
Alexander.
yes.
I mean, I understand it's important. But what I'm talking about is every patient that is in the hospital that would be removed from a ventilator, okay, is removed from a ventilator by substituted consent. When euthanasia is fully gone through the percolation of medical school training and all of these things, and the legacy generation of professionals has disappeared, it's obvious that you're going to have euthanasia by substituted consent. This is, so we can talk about expanding the criteria so that more and more people can choose it, but that's not the real game here. The real game is this thing. I'll stop. But the liquidation of the incapable population.
So first of all, I just want to say that the proponents of infanticide in Canada today are not quacks, right? It's important to emphasize that this includes the Quebec Medical College, right? This is an institutional level, right? Like, these aren't just like random, pro-MAID lobbyists, right? This is the Quebec Medical College advocating for infanticide.
Absolutely.
And the other element I just wanted to mention just very, very quickly is that I actually wrote in the cover story for National Review that covered some of the problems with waivers of final consent. Because in Canada's criminal law, all that is required is it needs to be a written agreement. It doesn't need to be signed. It's only with one physician. The other MAID assessor doesn't even need to be aware of it. Family doesn't need to be aware of it. The family physicians do not need to be aware of it. It's only a written agreement, no signature. And I wrote about a video where MAID providers in Canada were openly laughing. The other element I just want to say briefly is that in the waiver of final consent, there's an asterisk, which is if a patient has any intentional verbal or physical resistance, right, then that waiver is no longer in effect. Well, physicians in Canada have already talked and were laughing about administrating hydromorphone. So administrating a sedative, because if a patient resists the sedative, right, that is not resisting MAID, right? And they were talking about sedating a patient first and then administrating MAID. And they were talking about doing this in a way that family members would be unaware that it is happening, right? So look, this is a conversation that they had, right? One of them said that he personally did it. We don't have any evidence about this in any other way, right? There's no documented evidence. How could there be? But I'm concerned that with the waiver of final consent, that we're already entering the territory where we have non-consensual MAID happening in Canada right now, and that has already happened.
Okay, so it's 3:23 on my time. I think that we've gone long enough. Now, what's going to happen, Alexander, is that after your next paper comes out, or even maybe before then, we should maybe do this again, because there's been so much discussion that I think this video is going to get a lot of hits, and most of these people will come back. So that's another discussion in the future as to when that timing would be. But I think these type of discussions, as much as they can seem a little bit depressing at times, are sort of important, because they get you really understanding where we're at, because you need to know where you're at in order to be successful, able to fight it, So I thank you for your time. I thank everyone who asked questions and who joined us. At our top point, we had 65 people join us, which and that's not bad, but I mean, the fact of it is we had a lot more people sign up, and there'll be many people who will see it once it's put on YouTube, etc. And I'll make that link available to people. It's been recorded for that purpose. Thank you very much.